he also coughs, but his cough is not effective enough to clear his secretion. So that is one thing that I have noticed, and I think that is not covered in this list, and that is a very common thing that I have seen in my patients. So that is one thing that I wanted to share.
Very,
What do you
very
think about it?
nice. Yeah, excellent point brought up, and I couldn't have explained it better. So thank you, Prabhat, for sharing that with all of us. So, okay, so moving on. So, okay, now cough may fail to clear secretions as we talked about, and we talked about few conditions. So now I wanna ask you, I wanna give you a clinical scenario, and I wanna know what you think about this patient. So if a patient comes and says that he's been coughing, and then you take a listen at him with your stethoscope, and you feel that okay, this patient has bronchitis, wheezing, and is also clearly short of breath when you see that patient, because using accessory muscles and respiratory rate is high, and then you take a further more history, and that the patient says that he just moved in a new house and he was cleaning up. So what kind of diagnosis do you think this is?
Hello?
Yeah.
Yeah, so I think if the patient has shortness of breath and after he cleaned his house, then that opens up the possibility that he has an episode of an allergic reaction or bronchial asthma. But at the same time, what I've read and what I've experienced in my clinical practice is that cardiac diseases can also cause wheeze. This is termed as cardiac wheeze. So, in a patient with heart failure, fluid can build up in the lungs, and this can lead to narrowing of the airways and wheezing. So, just because of the presence of wheeze, we can't rule in that the cause of shortness of breath is respiratory. So, we should continue workup for cardiac as well as respiratory diseases. We should keep in mind respiratory as well as cardiac causes, and the patient warrants further investigations. And that is my opinion on this patient.
Very beautifully explained, Prabhat. Thank you so much for letting us know that. And yeah, I agree. And also, I would take into account his history as well of cleaning house. So I would keep the cardiac differential in my list, but definitely asthma would be higher on my list of differentials. But beautifully explained, and thank you for bringing that to our notice. Okay. So I have another scenario. So now this patient is a long time smoker and is having early morning, like productive cough. So what do you think this is, given the history of long time smoking and early morning productive cough?
COPD.
Okay, and what kind of COPD?
Chronic bronchitis.
Yeah, thank you, Syed. Would you want to shed some more light on chronic bronchitis since you said that?
Yeah, it is basically the inflammation in the bronchus that's like there is increased inflammation in the bronchial mucosa, and that causes accumulation of the cough, which is more pronounced during the early mornings.
Okay, okay, thank you. Yeah, so that would give us a clue into chronic bronchitis, and that's a separate topic for discussion on itself. So moving on. So yeah, so basically, in all these conditions, in the two cases we discussed, a key thing was that the duration of cough. So in asthma, so let's discuss first the duration of cough. So can anyone tell me what is acute, subacute, or chronic cough?
Yeah, so I find this very interesting because in the case of cough, the durations are very clearly defined. Acute cough is defined as having a duration of less than 3 weeks, 3 to 8 weeks for subacute, and more than 8 weeks for chronic cough. And I find this very convenient because in most of the different symptoms, we don't find this kind of clear-cut margins in differentiation of acute and chronic symptoms. So I find it very interesting that for cough, this is very clearly defined. So that's all from me for now.
Yeah, perfect. And as Prabhat beautifully explained again, that there's acute, subacute, and chronic cough. And based on these timelines, you can really kind of differentiate what are the causes or etiology of the cough of this patient, and kind of helps you put those things into few buckets. So, talking about acute cough, it can be due to respiratory tract infection, or it can be due to aspiration of any kind of food contents, or it could be due to inhalation of some noxious chemical or smoke, or even like asthma can cause an acute onset of cough. So, those are few. Or even foreign body ingestion can cause a cough. So these are few things which can cause acute cough. Then there are few conditions which can cause subacute cough, like residual tracheobronchitis. So what I mean by this is that supposing a patient had tracheobronchitis, inflammation of the trachea and bronchi, and then it the it persists even after the particular condition has resolved, and so it's called residual tracheobronchitis. It is commonly seen in pertussis, which we don't see much anymore. And then there is post-viral tussive syndrome. That is that when usually after viral infection, the patient will still have a residual cough ongoing for almost like 2 months. So that is one of the causes of subacute cough. And then there is chronic cough, which is more than 8 weeks. And that is mostly due to the cardiopulmonary etiologies and inflammation, infection, neoplasm, and all these causes. Anyone want to add any other causes in these buckets for me? Okay. So now the patient comes in and says that I'm having cough, and they define a particular, say, they say that they are having cough for now like 3 weeks. So the initial test for cough is what? It's a chest x-ray, right? And why do you think a chest x-ray is important? So it is important for us to, so we already discussed based on the mechanism that there are many stimuli above above the level of the chest, like in your nasopharynx, in your larynx, which can give a trigger to cough. And obviously, if they are not due to any underlying pathology within the lung, the chest x-ray is going to be normal. But you still need to get a chest x-ray because you need to know more information as to why this patient is having a cough. So can anyone give me few examples of a normal chest x-ray, but a patient having cough? We discussed few of them initially, just in the start of the session.
Hello.
Yeah.
Yes, so the patient might have a normal chest X-ray if he is suffering from, like you said, any pathology of the upper respiratory tract, like the common cold or a bacterial pharyngitis. If any of these causes are leading to the cough, then the patient will have a perfectly normal chest X-ray. Some pathologies other than these include uh, for chronic cough, for patients with chronic cough, if the patient has a gastroesophageal reflux, or if the patient has a post-nasal drip or a chronic rhinosinusitis, or if the patient has a reaction to drugs. For example, some drugs include ACE inhibitors and also calcium channel blockers, then these patients can have a cough with a perfectly normal chest X-ray.
Yeah, that was a great explanation. Thank you. Is anyone trying to say anything?
Okay.
Okay. So yeah, that was a great explanation. Thank you, Prabhat. So yeah, as he mentioned, that cough, even asthma can just present as cough. So cough, that's called cough variant asthma, or GERD, or rhinosinusitis with excessive drainage, nasopharyngeal drainage, which is causing your postnasal drip, and ACE inhibitors. So yeah, so all these things can cause cough and have a normal chest X-ray. So now I want to get into assessment of cough. So physical exam findings can really clue us into what is the cause of the cough, and especially like what is causing the cough. So can anyone tell me few physical exam findings for a patient who's having cough with different differentials?
Hello, yes, sure. So we should start the examination of the respiratory system with an examination of the upper respiratory tract. So if we look at the nose of the patient, then we might find an inflamed mucosa or polyps in a patient with chronic rhinosinusitis. And we might also find some discharge from the nose. And if the patient has bacterial pharyngitis or bacterial tonsillitis, then we might find inflamed mucosa in the throat, or an inflamed tonsil, or pus points over the tonsil or over the posterior pharyngeal wall. So these are some of the findings in the upper